Hi everyone. This week I'm going to introduce you to the solid tumor rules by explaining why we use this manual and how to use it. Let's review the first part of the manual, the general information for the solid tumor rules. The solid tumor rules are used to determine the number of reportable primaries that you will need to abstract for the patient you are working on. These solid tumor rules are not used to determine if a case is reportable or not. When you use these rules, you should already know that the case is reportable. These rules are also not to be used to stage a case or assign the grade of the tumor. Rules are to be used to determine if you need to complete one or more abstract and how to assign the histology code. There are notes and examples added to the rules for clarity. Make sure you read them. Never code multiple primaries based only on a physician's statement of recurrence or recurrent. There are two different meanings for the word recurrence, so make sure you read the note pertaining to this on page 10 of the general instructions. And last but not least, remember that you do not count metastatic tumors when you use the multiple primary rules. If a patient has a single colon tumor and 3 metastatic lesions in the liver, the patient is considered to have a single tumor, one tumor, because the tumor or the tumors of the primary site are the only ones that are counted when using the multiple primary rules. So even though the patient has one tumor in the colon and 3 tumors in the liver, we only count the one tumor because there's only one tumor in the primary site of the colon. We use the solid tumor rules to determine two things. One, how many primaries we have by using the multiple primary rules. And two, how to assign the correct histology code by using the histology rules. Let's review the multiple primary rules of this manual first. As I stated a moment ago, the multiple primary rules determine the number of primaries or the number of abstracts that you must complete. For all the site group modules, for the multiple primary rules, there are 3 sections. The first section is unknown if single or multiple tumors. In other words, you do not know if the patient has one tumor or multiple tumors in their primary site. If you have the pathology report, you should know this information. This section should be used very, very seldom. The second section is single tumor section. And this is the patient has a single tumor in their primary site. So if the patient we're working on has one tumor in their primary site, we would go to that section. And then the third section is multiple tumors. This we would go to if the patient has 2 or more tumors in their primary site. All right, so we count the number of tumors that we know are in the primary site, and we go to the section that's applicable to our situation. Make sure you are under the correct section header to determine the correct rule to use. Each section has its own complete set of rules, and we'll look at this in more detail in a few moments. We use the histology rules to determine how to assign the histology code for the abstract we are completing. We need to make sure we review the equivalent terms and synonyms that are listed before the histology rules. We need to make sure we are all talking the same language when using these rules. The histology rules may contain tables for combination or mixed codes and may contain a table of histology types using the different subtypes and variants of that histology. The histology rules will refer you to these tables if you need to use them to determine if that is the correct rule to use for the case. And it most likely will give you the histology code to record in your abstract. So you might not even have to use the ICDO manual for your case when assigning that histology code. Make sure you use the tables as directed by the histology rules. Like I said, the rules will tell you when to refer to these tables. And before using these tables, make sure you review and reread the instructions and notes that are before that table. There is important information that you need to know before using each of the tables. For instance, for some tables, you only use the histology code from the table when the diagnosis is exactly the term listed in the table. For the solid tumor rules, we do not use the ambiguous terminology lists that are in the SEER and the COC manuals to code histology. This is documented in each of the site group modules. Reason is it is repeated for each and every site group module is it's very, very important. Remember that the ambiguous terminology list is used to determine if a case is reportable or not. It is not to be used for every aspect of the cancer registry work. So remember that ambiguous terminology list that's in the STORM manual is used to determine if we need to accession a case or not. Now the rules need to be used in the following order. In other words, read before you begin. So first, read the general instructions for the site group module you need to use. Then read the equivalent terms and definitions. We need to make sure we are talking the same language. Too many times we assume we think things mean the same when they really do not. And sometimes we think things mean the same and they are not the same. So make sure you review those definitions and terms prior to using that module. Then we use the multiple primary rules to determine if we must complete one or more abstracts. And last but not least, then we use the histology rules to assign our histology code. Sometimes the rules will give us the code, and sometimes we will have to look the code up in the ICDO manual. So first, we need to read instructions, read equivalent terms and definitions. Then we use the multiple primary rules. Then we use the histology rules. How do we use the rules? Whether you are using the multiple primary rules or the histology rules, the rules are in hierarchical order within each section of the site group module. Each section is a complete set of rules, and that is why it is so very important we make sure we are looking under the correct section header. We have a single tumor or multiple tumors. Once we get to the rule that applies to our case, we stop, and that is the rule we use. Do not, and I repeat, do not continue to see if a different rule fits better. That is not how these rules were written to work. Once you get to the rule that applies to your case, stop. Do not continue to read. You will want to, but if the rule matches your case, stop, okay? Do not look for something that fits better. If it fits, you stop, follow the rule. This is an essential component of these rules, because if you do continue to read other rules, they may fit your case as well. And if this happens, you may likely do the incorrect thing. So read a rule and say to yourself, does this fit my case? If it does, stop and do what it tells you to do. If it does not fit your case, continue to read to the next rule. In the equivalent terms and definitions portion, there's actually more than just a list of equivalent terms and definitions. This section also includes changes from the 2007 multiple primary and histology rules. This is like a summary of what is different within the rules. What changed from the 2007 MPH rules to the new solid tumor rules. You may not want to read this portion of the rules since it may confuse you. This is really just to point out the major changes to registrars that have worked with the old rules. Then there is the list of equivalent and equal terms. Sometimes there will be a list of terms that are not equivalent or equal. Then there are the different tables, and each site group module is different for the types of tables it may have. There might be a table with site codes to assist you in recording the accurate site code or topography code. There's usually a table that has combination histologies listed with the appropriate code. And a table with the reportable histologies and their subtypes or variants of the more general histology names. There are actually a couple of site group modules that have tables that list histologies that are not reportable according to COC. And there may even be a table pertaining to paired site. And finally, this section ends with the illustrations, and there are usually several. These are great to use for referencing the anatomy and other important information pertaining to that site or sites within that site module. The second portion of the module is the multiple primary rules. Now, how do we use the multiple primary rules? First, we have to choose the appropriate section, and we do this by counting the numbers of tumors. Remember, this is the number of tumors in the primary site. Do not count metastatic lesions. If you do not know the number of tumors a patient had or has, then use the unknown if single or multiple tumors. Hopefully you won't have to use this module, but if you have to, then go ahead and use it. If you determine after reading the multiple primary rules that the patient has a single primary, then you complete one abstract. If you determine that the patient has multiple primaries, then you complete 2 or more abstracts. There are times that biomarkers may identify the histology type of a patient's tumor. However, do not code multiple primaries based on biomarkers. At this time, it has not been determined whether biomarkers can be used to identify multiple primaries. So biomarkers can be used to determine the histology and help us code the correct histology, but cannot be used at this time to determine if the patient has multiple primaries or not. Within the site group module rules, there are timing rules used. The timing rules differ for each site, so don't even try to memorize these rules. Actually, none of these rules should be memorized. This manual should be used daily by a registrar when abstracting. This slide has two examples of how timing rules are used within the rules. We need to note that 1 year equals 365 days. So if a patient was diagnosed with a tumor on January 1st, 2019, and the second tumor was diagnosed January 1st, 2019, that is 1 year exactly, or what they consider within 1 year. Less than 1 year is obviously less than 365 days. And there is an example here, as well as an example for more than 1 year. Figuring out the timing of more than one tumor is as easy as this is. Okay, so don't make the timing rules any more difficult than they are. The timing definition pertains to the patient being clinically disease-free, or the patient has had no evidence of a recurrence on follow-up. This is very important. When there is a recurrence less than or equal to the specified years of diagnosis, the clock starts over for these rules using the date of recurrence. What does that mean? It means if the patient has another tumor for that site, the time interval is calculated from the date of last recurrence. Okay, so the timing clock starts over. The timing interval is no longer determined by the date of diagnosis, but by the date of last recurrence. So this happens most often with bladder tumors. Okay, so a patient is diagnosed with a bladder tumor January 1, 2018, treated disease-free. Okay, 6 months later, on June 1st, 2018, their bladder cancer comes back. We use our rules. It's considered a recurrence. Okay, so the patient is once again treated for that bladder recurrence, all right, and is disease-free. So the clock starts over then, okay? So now the point of reference that we need to restart the clock is the June 1st, 2018, okay? So every time the patient has a recurrence and is disease-free, that time, that clock starts over from the date of the last recurrence. It's no longer the date of diagnosis. That's very, very important when it comes to bladder tumors. If you have a patient that has a recurrence, but you do not know if that patient had a recurrence in the past, then compute the time interval by using the date of diagnosis. You just assume that the patient has not had a recurrence since they were diagnosed. So if the patient was disease-free for 2 years and no one says whether they were disease-free that whole time or not, but there's no documentation that they did recur, we assume that they did not recur. We must use the multiple primary rules as written to determine whether a subsequent tumor is a new primary or recurrence, with one exception, okay? Whenever you're abstracting a case that's dealing with multiple tumors, you always need to pull out the multiple primary rules, okay? Except for one exception. If a pathologist compares the pathology slides from the subsequent tumor to the original tumor pathology and documents subsequent or the current tumor is a recurrence of the previous primary, then we would not use the multiple primary rules, okay? And we would record that subsequent tumor as a recurrence because the pathologist stated that and proved that it was a recurrence by comparing the two pathology specimens together, okay? So if the pathology report says this tumor was compared to the patient's previous tumor and it is a recurrence of that original tumor, then we just record that subsequent tumor as a recurrence of that original primary. Okay, so that's the one time we would not have to pull out our solid tumor rules and use the multiple primary rules. Now onto the histology rules. All right, so when we use the histology rules, we need to pay close attention to the two sections: single tumor and multiple tumor abstracted as a single primary. Some site modules might have more than two sections, but we'll get to that in a bit. I have an example of that. But once again, each section is a complete set of rules, and these rules are, once again, hierarchical. When you get to the histology rule that applies to your case, what do? You stop. Do not continue to read on. Always code the histology that was diagnosed prior to neoadjuvant therapy. Neoadjuvant therapy can change the histological profile of the tumor, so we want to make sure that we use the histology information given to us prior to that neoadjuvant therapy. So we would use the biopsy information to assign the histology code because that patient received neoadjuvant therapy before having their surgical resection. We need to code the histology assigned by the physician, which includes the pathologist. Do not change the histology in order to make the case applicable for staging. There are just some cases that should not be staged. I know a lot of people have, they don't like doing unknowns, but there are times that we have to do and record things as unknown. So if your patient's histology is not one that needs to be staged, then just don't stage it. There are lists of terms that can and cannot be used to code histology before each set of histology rules. These may be different for each site group, so make sure that you read them carefully each time you use that site module. We only code histology when described by ambiguous terminology only when histology is clinically confirmed by a physician, and that physician can be an attending physician, a pathologist, oncologist, any type of physician. The patient is treated for the histology described by an ambiguous term. The case is accessioned based on a single histology described by ambiguous terminology, and no other histology information is available or documented. All right? And there is a note that states, if the histology described by ambiguous terminology does not meet the three things that I just stated, do not code that histology. And when I say ambiguous terms for histology, there are a list of ambiguous terms in the solid tumor rules. Okay, so that's what they're referring to when they talk about ambiguous terminology. Once again, the ambiguous terminology list from the STORE manual is used to determine reportability, not to determine histology. You're going to hear me say that 1,000 times because it is so very important, and there are actually still registrars that are doing that incorrectly. When it comes to assigning the correct histology code, you need to pay close attention to the priority order of the source documents to determine how we assign the histology code. Priority order will differ by site. For each site group module before the histology rules, there is a list of documents in the order in which they should be used to assign the histology code. Once again, the priority order will differ by site, so do not try to memorize this information. Pathology tissue and/or biomarkers, if applicable, always take precedence. However, there are times when a case is clinically diagnosed and the priority of specific imaging scans used for that abstract can differ by site group as well. Having this list of documents in priority order will ensure that we are assigning the histology codes consistently throughout all registries, and all registrars are doing it consistently the same. All right. An example of priority order would be the pathologist says one thing and a physician calls the histology something else. You use what the pathologist wrote on the pathology report. The pathologist is the one that looked at the specimen. They know the histology. They looked at it. They named it something. It doesn't matter if the physician calls it something else or uses a different name. We have to use the pathology report to assign the correct histology code. At this time, I'm not going to go through all the rules for all the different site group modules, but I did want to look at what the site group documents look like. The format of the different site group modules is very similar, so that makes using this manual very, very user-friendly. These are the different sections for the breast solid tumor rules. First, we have the introduction, which is part of the print screen here on this slide. You will see that several of these notes will be consistently documented for each site group module, but there may be site-specific information, so make sure you read this for each site group module. The next section is the changes from 2007 multiple primary and histology rules. Once again, this is a great summary of the changes that were made for registrars that have used the MPH rules in the past. Since you have never used these rules before, you should just pay attention to the rules we are using and ignore this section. It may, make things more confusing for you. Then there is the equivalent or equal terms list that all site group modules have. Some site groups have a list of terms that are not equivalent or equal, as the breast does here. Then there are the tables that we talked about earlier. Breast is one of those site groups that has a table pertaining to assigning the site topography code. Before the table, it once again explains exactly what column 1 represents, which is the terms used to describe the location or site of the tumor, and then column 2 contains the site term and code. So the terms and descriptive language are used many times by surgeons and pathologists. However, that terminology isn't provided in the ICDO manual. So having this additional descriptive language written here with the the assigned topography site code listed there. It makes this a lot easier and makes the data more consistent. So this is a great table to use if the ICDO manual doesn't use the exact terminology that you have in front of you from the medical record. Then we have another table with histology combination codes. As you can see here, we are given instructions in how to use this table. Make sure you read the instructions and do not just skip to the table if the histology rule references a table. These instructions are essential to using the tables correctly. Here is a portion of Table 2. The first column lists the histology terms that are required in order to assign the combination code. So you look at column 1, and then column 2 tells you what to do. For the breast site group module rules, there is a table 3 that lists the specific and NOS, not otherwise specified, or NST, no special type, and subtype variants of the different histologies for breast cancer. If the histology rules tell you to go to this table, make sure you read the instructions, or in this case, the notes before using the table. As you can see, note 4 states, only use the histology code from the table when the diagnosis is exactly the term listed. This is obviously very important for consistent coding of the patient's histology. There's also an additional paragraph that explains column 3 in more detail, so you better understand how to use this table. Always read the notes and instructions prior to using the table. And don't worry, you will know when to use the table because the rule will tell you to use the table. And it tells you exactly which table to use. As you can see by this table, some specific and NOS terms and codes have subtypes or variants and others do not. Some histologies do not have synonyms or subtypes, so we need to make sure that the diagnosis is stated exactly as written in the table. All right, so the specific or NOS, NST term codes is the first column. If that tumor, that histology has any synonyms, words that mean the same thing, they would be listed in the second column. That just means that what's written in the first column means the same as what's written in the first column is the same as what's written in the second column. And then the third column is subtypes or variants. These are more specific types of that NOS or NST term, okay? So if what our patient's histology is listed in the third row, exactly as written, then that is the code we would assign. As you can see, they're telling us the code to assign for that abstract, so we would not have to use the ICDO manual in some of these cases. Then we have the illustrations. There are 2 of the breast illustrations that are included in the manual on this slide. I think that the clock positions, the quadrant, and codes for the breast is the most used illustration when it comes to breast cases. So you will definitely want to keep this illustration close by. You will be referencing it often. Like I said, I'm not going to go through the rules themselves at this time, but I do want to go over the format of the rules. So the breast multiple primary rules begin with note 1, okay, and note 2. Just 2 reminders. Note 1, do not count metastatic lesions when counting the tumors. So you just count the number of tumors that the patient has in that breast. Note 2 explains which rules to use and when. For instance, bullet 3. If the original tumor was diagnosed before January 1, 2018, and a subsequent tumor is diagnosed after or January 1st, 2018, we must use the 2018 solid tumor rules. All right, there's no need to pull out the old MPH rules. So this is really, really good. This makes our job a lot easier. So if you have a tumor from 5 years ago and a new tumor now, just use the solid tumor rules. These 2 notes are provided for each site section. Now the first section for each site group module for the multiple primary rules is unknown if single or multiple tumors, with the corresponding rule and what to do. If we know what number of tumors we are dealing with, if we know how many tumors the patient has, we go to the next section, all right? Rule M1 should be used very, very rarely, since you should have this information when abstracting, especially if the case is an analytic case. The next section is for single tumor. And then there's a section for multiple tumors. If we have a single tumor, we begin to read the rules at M2. If our patient that we are abstracting has inflammatory carcinoma of the breast in one or both breasts, we would stop at rule M2, which tells us abstract a single primary abstract when a diagnosis is inflammatory carcinoma in multiple quadrants of one breast or it is in both breasts, all right? If our patient does not have inflammatory carcinoma, then we go to the next rule. And if the patient only has one tumor, then this would be the rule we would use. So single tumors is quite simple. There's only 2 rules, and inflammatory carcinoma isn't that common. So just 2 rules. Breast patient has one tumor in the one breast, we use M3. That fits our case. As you can see here, if the rule pertains to a table, there's a hyperlink that you can click and it will bring you to the instructions for that table, okay? And the table follows the instructions, all right? So it's gonna bring you, if you click on that hyperlink, it's gonna bring you to that table where the instructions are. Read the instructions and then continue on to the table. Okay, so once again, you would read the rules until you get to the one that applies to your case and stop. If it instructs you to refer to a table, then go to that table, all right? I know these links are here, but you really need to use your hard copy manual, okay? And during study group, I will explain how you should tab your manual, okay? You can tab your manuals so that you can go very easily to table 1, 2, or 3. In this case, for breast, there are 3 tables. So, for your CTR exam, you actually have to use this manual to answer many questions, okay? So please use your hard copy until after you take your exam. Then if you want to use the electronic manual, by all means, go ahead. It's just really important that you get used to using the manual prior to taking your exam. Getting used to flipping back and forth between tables in the different sections will save time when it comes to taking the exam. You need to be very familiar with using the hard copy and become efficient doing it to save time when you are taking the exam. If you are not familiar and efficient, you will run out of time taking the exam. I've known people that have failed the CTR exam because they had always used the electronic version, and when it came to the test, they just were too clumsy using it that they ran out of time. So please, please use your hard copy for the next 2 semesters. Before the histology rules begin, there are coding rules for cases that have multiple histologies in a single tumor. Once again, pay close attention to the notes provided and the instructions. Some instructions are listed in priority order, all right, as we see here. So if the case you are working on has multiple histologies in a single tumor, make sure you read these rules before going to the main rules. There are important notes about coding the histology when a patient has neoadjuvant treatment. We discussed that earlier. The next section lists the order in which you need to use the documents of the different types of tests performed on the tissue, and these reports may also have a priority order when it comes to the report itself, all right? Kind of what I started to discuss now. So this is that section for the breast primary module. It's very important to read this carefully and refer to it often as needed, for it is stated very clearly how we need to use the pathology reports. If there is an addendum made to the report, we need to use that information and not the information that is included in the final diagnosis or synoptic report. Sometimes there will be a discrepancy between the final diagnosis and the synoptic report on a pathology report. These rules tell us which should we use. Should we use what's stated in the final diagnosis or the synoptic report? This seems very overwhelming, but it's really not, because you know, when it comes to that situation, you're like, oh, what do I do? What do I do? And it's telling us exactly what to do. So we just need to read the rules and do what they say. Then we get to the rules themselves. For breast, the first section of the histology rules is single tumor in situ only. Breast has more histology sections than other site group modules do, so make sure you are under the correct header. This is essential to using the correct rule, all right? So the first one is single tumor in situ only. This means the patient has one tumor and it is a non-invasive in situ only cancer. Then we would go to this section. Now there are 4 sections, 4 histology sections for the breast. The single tumor in situ only. Then there's the section for single tumor invasive and in situ components. So that's when a patient has one tumor, but there's invasive histology and non-invasive or in situ histology in that one tumor. And then there's single tumor invasive only. That we would go to if the patient's one tumor only had invasive tumor to it. And then the last section is multiple tumors that we need to abstract a single primary. So once again, make sure you are under the correct header. I recommend that you highlight the headers of each section for all the sites. This is what I have done, and just by having those highlighted remind me that I have to make sure I'm under the correct section. When I didn't have them highlighted, I wouldn't even look at the sections. I wouldn't look at the headers. But now that I have them highlighted, that's the first thing. I look at the highlighted and it's like, oh yeah, are you under the right section? So it trains your brain to do what it needs to do. Now for this week, read the Solid Tumor Rules General Instructions. If you have not received your manual yet, the Solid Tumor Rules Manual is provided in this week's reading folder. It's also in the resources folder. I realize these rules are going to sound confusing and overwhelming until you get to use them. However, we must first understand how to use the rules and know the general rules prior to using the rules. So that's why it's very important that we're doing this assignment to get you used to the general rules. Please make sure you participate in the discussion and complete your assignment this week. After you have completed your assignment, view the recording that is titled Solid Tumor Rules Practice Cases. Using 4 different cases, that presentation walks you through exactly how to use the rules when you have the case. All right, so that will prepare you for what you need to do next week. Hope you will join me for our weekly study group webinar, but if you are not able to attend, remember, I do record the meetings and they are provided in the study group webinar folder in the Abstracting 1 course. Remember, these rules should not be memorized. You need to pull out this manual for each and every abstract you complete. Yes, you may be able to easily determine that you only have to complete 1 abstract for a case, but you still need and must use the histology rules to assign the accurate histology code. Using the histology rules makes assigning the histology code so much easier for us. So make sure you read, and read some more, okay? The more familiar you are with these documents, the easier it will be for you to take your CTR exam. Have a great week, everyone.